Hi there, my name's Paul Sampson. I'm a consultant anaesthetist at Derriford Hospital in Plymouth, and I'm going to be talking to you today about anaesthesia for traumatic brain injury. And this is a recorded talk for the Head Start course. This is a brief outline of what I'm going to be talking about. I'm going to be particularly aware of not going into the ICU management of these patients, as it's outside of my expertise. However, there will be some crossover. I'm also cognizant that, like always with anaesthesia, there are multiple ways of doing things, and you are very likely to see different approaches to anaesthesia for traumatic brain injury. But hopefully this talk will give you a framework for approaching these patients. So traumatic brain injury is fairly self-explanatory. It is a severe pathology due to a violent blow or jolt to the head, leading to altered neurology. It's a leading cause of death and disability and has significant social and economic implications. And we see that it's most common in males, and there are the peak frequencies are at age 0 to 4, 15 to 24, and then in your more elderly comorbid patients, that's above 65 years of age. The most common causes are road traffic accidents, falls, sports injuries, and occupational accidents. We can think about the pathophysiology in two ways, really. There's usually there may be a focal injury, such as a skull fracture or contusion, and this may be associated with blood in the brain. And this is either subdural blood, extradural blood, subarachnoid blood, intraventricular blood, or parenchymal blood. There may also be no blood, but a significant diffuse injury, and this is known as diffuse axonal injury, and we'll touch on that a bit later on. You may also have diffuse vascular injury, potentially with some microhemorrhages or brain swelling. It's important to remember with patients who've had traumatic brain injury that it's not just the blood in the brain that may cause us issues, but traumatic brain injury is a systemic disease with systemic consequences. And the ones that may complicate our anaesthesia are particularly lung injury, and that tends to be edema and infection due to barrier permeability. And cardiac, usually reduced left ventricular ejection fraction or arrhythmias, and also less potentially causing problems for us as anaesthetists, but more so in the intensive care units are gut, renal, hepatic, and neurological consequences. It's usually classified based on the GCS, and as your GCS goes down, your mortality goes up. It can also be classified based on the cause or the type of injury to the head or the brain, and that being either blunt, penetrating, or blast. As anaesthetists, we will see all ranges of these patients from mild to severe traumatic brain injury in our anaesthetic room. So I'm going to have a look, just a brief overview of some of the pathology that we might be involved with. None of these are going to be particularly new to you. Hopefully will serve as a bit of revision. This is a CT scan of an extradural hemorrhage, and these are usually due to result from direct impact to the head, leading to a middle meningeal artery tear, and it's usually associated with a fracture of the temporal bone. You're classically taught that the patient experiences a lucid interval followed by rapid deterioration, and this does seem to be the case in 50% of patients. These patients need expeditious transfer to a neurosurgical theatre, and that's mainly really because they can have a good outcome. And I've certainly been involved with patients that were, had very low GCS at scene with an extradural hemorrhage, brought over from another hospital to Derriford, and then the following day I've gone to see them and they've been sat out in the chair. We'll talk about the anaesthetic parts a little bit later, but the main management surgically for extradural might begin initially with a burr hole for urgent decompression, but that will either, or the neurosurgeon will start with or proceed to a craniotomy, essentially to remove the clot and stem the bleeding vessels. Acute subdurals, these are due to tearing of the bridging veins that lead from the brain to the dural sinuses. Bleeding ultimately stops due to a tamponade. However, there may be ongoing neurological injury due to that blood in the brain. And this is, you either see patients with this type of injury being high velocity trauma, so your younger patients, or minor trauma in elderly patients on anticoagulants. It's more common in elderly patients with minor trauma because of increased brain movement in the cavity due to atrophy as the patient gets older. The underlying brain damage with an acute subdural tends to be more severe than that of an extradural. So we may not see many of these bleeds. They may be managed in another hospital with neurosurgical input and managed conservatively, looking at any progression particularly in terms of mass effect. There's a risk of clot expansion within 36 hours, so patients may get a few CTs during that time. And there are some specific indications that the neurosurgeons will use to bring the patient to theatre. Surgical procedure is similar. It will be a craniotomy, but they'll breach the dura and then sew the dura back up. And they may, depending if this is a severe TBI, they may insert a bolt for ongoing ICU management and measurement of intracranial pressures. So it's unlikely that you'll see these next group of patients coming to theatre in the acute phase, as in just as the injuries happened. You may see them later on down the line. But a subarachnoid bleed, you may see Woods as an incidental finding, if you can call it that, in a patient who's experienced severe trauma elsewhere. And it may complicate intraventricular hemorrhage. A significant subarachnoid hemorrhage may subsequently cause hydrocephalus, and that's when you might see the patient in theatre coming for an external ventricular drain. Another injury pattern that we may come across later down the line in the patient's pathway is traumatic axonal injury. Fortunately, this is associated with a poor outcome and has a high association with death and severe disability. It's usually caused by road traffic accidents, falls from heights and assaults with rapid acceleration and deceleration or rotational head movement, and essentially leads to axonal disconnection and mechanical disruption to axonal cytoskeletal structure. If you want, you can have a quick Google of traumatic axonal injury and tractography, and that shows some useful MRI-based images showing how essentially white matter fibers are reduced in traumatic brain injuries compared to normal brains. So these are the procedures that you might see: ICP bolt, burr holes, usually in subdural hemorrhages with patients with a smaller bleed, and usually they tend to be the more elderly patients. Craniotomy for more extensive bleeds, external ventricular drains later down the line, or decompressive craniectomy for either as a primary management of a big bleed, or as more of a secondary procedure when they're struggling to manage ICPs medically on intensive care. So you guys have probably been involved in all of these parts of the pathway, so I won't dwell on them for too long, but patient with traumatic brain injury, does travel through quite a lot of different parts of the hospital, and we tend to be involved in most of those bits. When you first see the patient in ED, whether that's in the peripheral hospital or in the tertiary units, the workload can be quite heavy. You're ultimately trying to protect this patient's brain from getting worse, and by maintaining CPP, cerebral perfusion pressure, and reducing ICP. You may have to stabilize coexisting injuries, which may be leading to severe hypovolemia, and you'll be wanting to arrange the transfer of these patients, made slightly easier a bit now with Retrieve, but you may be the patient, the person bringing the patient over. I'm not going to go into transfer medicine in this talk. You may be having to manage a coagulopathy, and usually in the very initial instances, that will be a drug-related coagulopathy, so a patient on anticoagulants. Patient may have relevant comorbidities that might make your management difficult, and you'll be communicating with multiple people, so specialist centres, relatives, retrieval team, and your own team. You will then find yourself on the other end when you're receiving a patient that you've heard rumours about, and the story seems to change every 5 minutes. But it's nice to then see a friendly face bringing the patient over, and hopefully get a nice overall history of the patient with maybe a bit more detail. But equally, they may not have all the detail, and just by virtue of multiple handovers, elements of the history may have been dropped. So just be aware of that, but there's little you can do really. And the key elements that you want to know are the mechanism of injury, what the history of the neurology has been, particularly the M score, and neurosurgeons will be very keen to know what the M score was pre-intubation, and what the pupils have been doing. And then your usual anaesthetic bits of the history, focusing on, has the patient had any osmotherapeutics, antiepileptics, what's been done about any coagulopathy, what's the deal with blood bank, have we got them on side already, have there been any airway issues, and who is their next of kin. So anaesthesia for the traumatic brain patient has elements of emergency surgery, so issues related to emergency surgery. If you're seeing the patient as the first anaesthetist, you may have an uncooperative patient who's cerebrally agitated, or which may lead to difficulty placing lines, or you may have a really urgent situation where the patient's losing their airway due to their injury. You're taught that your induction may exacerbate neurological injury by causing either hypotension or hypoxia. So that's something that you're going to be cognizant of when deciding how to proceed. You may not have a full history, anaesthetic or medical history. And as I said, for IV access might be difficult. And you may have other injuries that will be that may potentially affect your induction, such as an unstable C-spine or pneumothoraces, or any other hypovolemic injury. So the main principles in my mind, this is taken out of my mind as opposed to any particular guidelines, is like with anything, there's a balance between safety and expediency. This patient needs to get to a place of neurological safety, and that's either a theatre, neurosurgical theatre, or a neurointensive care unit. But there's no point doing that in a hasty way that will put the patient at a higher risk of neurological injury. We want to try and avoid hypertension, avoid hypotension, and avoid any gross hypercapnia, hypoxia, or spikes in ICP. Airway management of these patients can be difficult due to C-spine injury, but I'll briefly touch on management of C-spine injury just by mentioning a paper later on. They're likely that they'll need a rapid sequence. I would tend to have a low threshold for videolaryngoscopy for these patients wherever you're anaesthetizing them. And then if you're anaesthetizing a patient, say in a neurosurgical center, where they'll then be going to an intensive care unit afterwards, there's an issue about whether or not you put a patient to sleep with a reinforced ETT for your sort of airway management to avoid any kinking of the tube intraoperatively. However, that tube will then likely need to be changed post-operatively. Depending on the length of the procedure, the difficulty of the airway, you may need to consider whether or not you go straight for a standard Portex tube with subglottic suction, just bearing in mind and being careful that when setting the patient up, that there's less risk of kinking. However, that will be taken on a case-by-case basis. Fine. So we always like to have an arterial line in these patients, ideally awake, but that's not always possible if the patient's uncooperative. Always be suspicious of pre-existing IV access. Make sure it's working well, and you may or may not be able to use processed EEG monitoring such as BIS pre-induction. So this would be if I was putting a patient to sleep in theatre for a craniotomy, essentially. You'll see different things being done. Okay, so this is just some elements of what I tend to think about drugs-wise. On standby, I'll have atropine, glycopyrrolate, hypertonic saline. I may give the hypertonic saline before induction. I've put it twice there for some reason. I'll tend to use, so assuming pre-oxygenation has been done and we've got IV access plus or minus an arterial line, I tend to use 1 to 2 mics of fentanyl. If the patient's really unstable, I might use some midazolam, or if they're particularly anxious, I'm quite happy to use midazolam. And I think in the context of a patient that might be staying asleep, I don't think that's particularly an issue. And I tend to always use Tiva, but that's a personal preference. If you find yourself that you need to use volatile, just tend to try and avoid going above a MAC of 1, and it's generally safe. The evidence tends to suggest that they're both safe for patients undergoing neurosurgery. The only evidence I believe to have a preference of for Tiva over volatile would be if you're struggling with brain relaxation intraoperatively. Tiva might have a benefit there. So I'll give my fentanyl. I'll start my remifentanil in mics per kilo per minute. I tend to use at 0.4, and I let that get into the system. However, Minto is useful as well. A bolus may be useful if the patient's particularly hypertensive, but obviously you want to keep an eye on breathing. I start the propofol low at an effect site usually of about 2, and I see what happens, watching the blood pressure, watching the patient. And then I might increase up by 1 or 2 again. There's no particular urgency, or you need. This is definitely would be what we'd call a modified rapid sequence induction. What you're trying to do here is avoid a big bolus of propofol causing hypotension. And obviously, what I forgot to mention is that I would be starting before all of this metramidol infusion at a generous rate, over 15 to 20 mils per hour, even if the BP is already pretty good, as I would quite reliably expect blood pressure to drop after induction. I tend to use a rapid sequence dose of rocuronium, and I would have Keppra ready to give intraoperatively. After induction, I'd put additional IV access. I'm quite keen on having a cannula in the foot, but that's not mandatory. It might be impossible. Urinary catheter is usually inserted. If it's going to be a quick decompression, that can wait till the end, or it can be done at the same time. As there's quite a lot of preparation and positioning, and that could probably be done at the same time, particularly in the man, but also in the woman. Mechanical thromboprophylaxis will usually be flotrons. It's unlikely that a a craniotomy for a traumatic brain injury will use a Mayfield clamp, but have a plan for deepening the patient when that's about to happen. And you may need head rotation and whole body readjustment, so they might want to put a big jelly underneath the patient to get the angle of the head quite just as they'd like it, to make the operation easier and hopefully quicker. So the patient, I'm going to briefly mention about when you're receiving a patient with traumatic brain injury from, say, Retrieve or a team from another hospital. The key is, don't just sit and wait for the patient to turn up and expect everything to be done, because that's very unlikely. Be proactive. Try and find out what the expected time of arrival is. Get your drugs ready. Get them in the pumps. Discuss your plan with the ODP. See what the surgeons are planning on doing, what they know about the patient. How are we going to know that the patient's arrived? I know that Retrieve are working on communication between us and theatre, particularly, so there's no sort of time wasted. I tend to give ED Theatre 6's number, or whichever, usually Theatre 6's number, to call when the patient's arriving, or that they've heard that there's an ETA of, say, 5 to 10 minutes. And then will blood bank need to be informed? And it'd be useful to give them a heads up. So when the patient arrives through your theatre doors, you'll have it's good to have a chat with the transferring team to have a plan of how to get the patient onto the theatre table. Is there any immediate concerns in terms of airway or bleeding, hypertension, or impending coning, perhaps? And then how are you going to transfer onto your ventilator, monitoring, and drugs? I tend to transfer onto our ventilator and then get everything across. But people will do things differently, and it depends. And I'm not going to go through every potential possibility here, but and you'll have your own system. I then transfer to TIVA, but you could transfer into volatile if you wanted to. I often get asked by trainees of how do we transfer onto TIVA, and I'll be honest, I'm not sure if there is an accepted way of doing this from mils per hour to TIVA, and I'm happy for someone to contact me to tell me if there is a way of doing this that is sort of accepted. But I tend to say if they're on 30, 40 mils an hour of, or more perhaps, of propofol, I will tend to, again, start on a TCI program of propofol, and I will start low, which would give me a small bolus, and then slowly get back up to the rate at which the patient was on, and then we'll possibly need to go higher for intra-procedure. And then I'll start the remifentanil, might give a small 0.5 mic per kilo bolus to get it into the system, and possibly a dose of fentanyl, 1 to 2 mics per kilo as well. But this is all keeping a very close eye on the blood pressure. I then transfer. You'll see people doing very different things, and that's what I find works for me. But that's definitely not possible. Then I transfer to our monitoring. The ODP will be hopefully all over securing the ETT, panning the eyes. You probably get a temperature probe in there, plus or minus BIS, and then have a good top to toe investigation of the patient's pressure areas. And this will be done along with the theatre team. Are great at doing this, really, particularly the HCAs, and the surgeons are good at. If you're worried about any part of positioning, don't hesitate to speak to the surgeons. And the neurosurgeons, particularly at Plymouth, I find are very cognizant of the airway issues and are happy to hold the head with the airway secure if you need to be doing something else. Okay. This is a slide from that paper below, just really an overview of some of the recent evidence and management of traumatic brain injury, some of which is relevant intraoperatively, some less so. So some of the things I didn't mention are administration of tranexamic acid within 3 hours of injury may reduce mortality, but not necessarily neurological outcome. Mentioned that levetiracetam is as useful as phenytoin. Hypertonic saline and mannitol reduce ICPs to similar degrees. There's no evidence in terms of crystalloid, but it's been you should avoid albumin. We try and aim for normothermia, and there's some recent consensus guidelines which I think Ash Williams has been involved with writing, and that's probably that's more intensive care related, but would be useful to have a look at. So it's worth looking at that paper if you get a chance. That's a slide from earlier. Intraoperative issues. So the main ones that I've kind of touched on, but bleeding will be a potential major issue, which goes without saying. The patient may be on antiplatelet or anticoagulant drugs. They may be receiving tranexamic acid. You may need to have blood brought into theatre, and it's important that the parent, i.e. neurosurgical team, are arranging that. Don't fall into the trap of arranging what blood needs to be ordered, especially if it can be done before the patient comes to theatre. Obviously, we'll be more than happy to give it. It's usually something that's being given to allow the operation. So we're fortunate that we've got Rotem at our disposal, and we can actually now look at the results on our laptops in theatre, which is great. I think I might touch on what you might see on a Rotem. And it's important intraoperatively to maintain good lines of communication with your surgeon about if they're happy in terms of bleeding. But I couldn't find a good picture other than this one, and there's a plastic bag at the head end. That's probably got a technical term, but just keep an eye on that, as that collects blood coming down directly from the surgical site and can fill up quite quickly, and the surgeon and the scrub team may not be aware of how quickly it's filling up. So a bit like obstetrics, you want to kind of be doing a walk around the patient and seeing if there's any blood collecting there. And also have a look at your suction cup. Traumatic brain injury and polytrauma. I couldn't find any obvious guidelines other than these bundles of care in the paper, in the second paper there. But I had a quick chat over email with Paul Moore and Jess Wellborn, and this is kind of what general principles we've come up with. You'll clearly be following your ETC or ATLS principles. You want to stop the bleeding, and that's either through proximal control or damage control surgery. Replacing the volume loss and trying to maintain cerebral perfusion pressure using volume replacement, really, and that's either going to be blood or possibly some boluses of fluid. If you need to, maybe some vasopressor therapy, but essentially once filled, then you can be more comfortable using vasoconstriction to maintain your CPP. And you'll be aiming for a CPP of 60 millimeters of mercury. And the other thing that comes out of these papers, I think particularly the second paper, is strongly considering ketamine as an induction agent. The top paper is very interesting to read. It's useful talking about blood pressure management and trauma resuscitation. Coagulopathy and TBI. Again, I'm not an expert in this, and these again some principles. On the left, there's an algorithm summarising the perioperative management of patients undergoing emergency intracranial surgery in the context of direct oral anticoagulants. So I'll let you have a look at that in your own time. They do talk about these particular antidotes, which I'm not sure we have available in Plymouth, but we do have PCC available. The other things to consider, though, are the systemic and side effects of massive transfusion. Conventional tests in traumatic brain injury tend to show low platelets and low fibrinogen. TEG in trauma usually shows us increased R time and reduced MA with evidence of hyperfibrinolysis. You usually might find yourself giving platelets, reversal agents such as vitamin K or PCC, and you want to avoid hypothermia, avoid hypocalcemia and acidosis, and you guys all know this, and whether or not you need to be setting up an infusion of tranexamic acid. I'm going to briefly mention some related papers. So this is the first one is the Rescue ICP trial comparing decompressive craniectomy versus medical management for refractory intracranial hypertension. So these are patients that will be in intensive care that they are struggling to manage their ICPs, that may come to theatre to have part of the skull removed to relieve the pressure and allow ongoing management. And unlike a previous trial called DECRA, which found similar mortality between the two groups, the authors of Rescue ICP reported a significant decrease in 6-month mortality in patients who underwent decompressive craniectomy when compared to medical management alone. However, the craniectomy led to higher rates of vegetative state, and more survivors in the surgical group than in the medical group were dependent on others. So there's another paper, very recent one, until recently, there's no evidence was available to support the use of decompressive craniectomy as a primary procedure. So when the patient comes in initially with acute subdural hematoma, and this paper found similar outcomes between craniectomy versus craniotomy for acute subdural hematoma. This is the crash-free trial that showed that TXA is safe in traumatic brain injury and that treatment within 3 hours reduces head injury-related deaths. This Cochrane review, essentially weak evidence suggests hypertonic saline is no better than mannitol. At Plymouth, we tend to stop 5% and give about 2 mils per kilo as a bolus, and we keep an eye on the sodium. This is a very good read. Essentially, airway, and I only put it here because patients with traumatic brain injury, you may be worried about their spinal cord. And essentially, this paper says that the risk of spinal cord injury during tracheal intubation appears to be minimal, even in the presence of gross instability. And we should essentially use the tracheal intubation technique, which we feel the most proficient in and that is most likely to minimize cervical spine movement. So essentially use what you're most comfortable with and think will give you the best chance. These are some very good resources with some significant, with very significant Plymouth input. A textbook on the right there, which Jess and Elfin, Prof. Whitfield have edited. The NACS curriculum resources, Ash Williams and Jess Wellborn created. So they link multiple resources to the neuro anaesthesia and neurocritical care Royal College curriculum. So very much worth a look. And the Brain Trauma Foundations is where you get your guidelines for management, management guidelines for traumatic brain injury. So that's it. I hope it was useful, and I hope to see you soon. Any questions at all, please don't hesitate to get in touch by email or come and find me. Thanks very much for listening.